Wolff-Parkinson-White (WPW) syndrome is a condition characterized by an additional electrical pathway in the heart, which is present from birth. This can cause episodes of rapid heart rate, known as atrioventricular re-entry tachycardia (AVRT). This accessory pathway does not delay conduction. As a result, atrial fibrillation (AF) can quickly deteriorate into ventricular fibrillation (VF). Distinctive electrocardiogram (ECG) features are the key to diagnosing WPW syndrome. Typically, a short PR interval is observed, which is the result of premature ventricular depolarization. Furthermore, wide QRS complexes with a slurred initial upstroke, termed a delta wave, are generally visible. This delta wave is a clear indicator of early ventricular activation due to conduction via the accessory pathway. The direction of the QRS complex can vary, contingent upon the location of the accessory pathway. Left axis deviation is commonplace if the accessory pathway is on the right side, while a right axis deviation is observable when the pathway is situated on the left side. WPW syndrome is further segmented into Type A and Type B, based on specific ECG findings. In Type A, denoting a left-sided pathway, there is a dominant R wave in V1. This presents as a positive QRS complex in V1. On the contrary, BWPW syndrome, signifying a right-sided pathway, does not display an R wave in V1. Instead, it typically results in a predominantly negative QRS complex in V1. WPW syndrome is also linked with other conditions. Hypertrophic cardiomyopathy, HOCM, a condition characterized by thickened heart muscle, can eventually obstruct blood flow and mitral valve prolapse, in which the valve between the left atrium and ventricle doesn't close properly, leading to blood leakage, are frequently associated with WPW syndrome. Other connections include Ebstein's anomaly, a rare heart defect present at birth causing the tricuspid valve to be displaced, thyrotoxicosis, resulting from a thyroid hormone causing rapid or irregular and secundum atrial septal defect, ASD, of congenital heart disease, where there is a hole in the wall that separates the top two chambers of the heart. The management of WPW syndrome often necessitates definitive treatment via radiofrequency ablation of the accessory pathway. Medical therapy may include the use of medications such as sotalol, amiodarone, and flecainide. It's important to note that sotalol should be avoided if atrial fibrillation is also present, as it could escalate the rate of transmission through the accessory pathway, potentially leading to a swifter ventricular rate and the risk of ventricular fibrillation.